everybody. Welcome. This is our first faculty development presentation with Dr. Stulberg. Thank you for being the first, Dr. Stulberg. Dr. Stulberg is a FAAFP award-winning teacher, professor, and vice chair of education in the Department of Family and Community Medicine at the University of New Mexico. He's a former residency director and preceptorship director. He focuses on faculty development and teaching in addition to his clinical practice. And he's a frequent presenter at national conferences, published numerous journal articles, case publications, chapters, and books. Thank you and welcome, Dr. Stulberg.
Thank you so much, Nicole. Thank you, Mario, also for your tech support. And thank you for all of you who are joining us today. And I understand we're going to be recorded. And so thank you to all of the folks who watch this at a later time. Really appreciate the opportunity to work with all of you today. And now we'll talk about our Faculty Development 101, setting up curriculum, how to give great presentations, and what makes for a great presentation. So some of you are just starting out. Some of you are going to be piggybacking onto another group's curriculum for part of your curriculum presentation. So I'll cover some things in general. If you're starting from scratch, probably the number one rule is don't start from scratch. Starting from scratch is really difficult. And there are so many good curriculums out there. You probably want to steal one, borrow one, beg for one, whatever it takes to get a structure and a template that then you can adopt to your own individual needs. There are even ones that are available, and I'll talk a little bit more about the Family Medicine Curricular Project in a moment. And adapting someone else's for your own is great too. And also I mentioned developing your own from scratch is tough. But if you like to, certainly is possible to do that. So in terms of where you might steal one from, all of you have been through a training program already, and you might have thought you got a great education and might want to reach out to where you trained and ask the leaders there if they're willing to borrow their templates of how they did their education. Or if you've got a colleague or friend that you know is doing a great job at another program, you can also ask them to share their resources because people in primary care training are usually very generous about sharing the work that they've done so that we're all more successful together. There's also another resource that is the Society of Teachers of Family Medicine, STFM. And as you go along in the development of your programs, it is great to be on the listservs from that group because when you run into a question, you can just fire off an email through the listserv and get between 2 and 10 responses from the group in terms of support and resources from around the country. When you run into a question, you can say, well, how did you do it in your program? And people say, well, we did it this way and it worked out great. And here's some documents and some examples that you can just incorporate into your program. So I've found that to be a wonderful, caring and sharing group. And the other thing that they have is the digital resource library. If you want to scan the QRS code, it'll get there for you, or there is the link there in part of the presentation. And this is a wonderful resource. So what the STFM has done over the years is they've invited people who've presented at their conferences to upload their materials onto their website so that people in the future can view those and look back and see what other people have done. And I find it an incredible resource. The only limitation is it sometimes can be difficult to search it because there is such a wealth of information. When you do your search, you're going to find a lot of hits. Sometimes if you've heard that a particular person presented, you could search under their name, or you could search under curriculum or curriculum development. So that's another wonderful resource. Now, if you'd like to buy a curriculum, the STFM actually has developed this. Mike Tuggy, I believe, was one of the big instigators. He's up at the Swedish program in Seattle, and they put together an ideal, what they thought was an ideal program for a family medicine curriculum. And in addition to all of the topics, and they not only list the topics, but if you purchase a subscription, they actually provide you with the presentations. So they have presentation materials developed out for all of the topics in the curriculum. So if you say you're just starting out and you've got faculty that are accustomed to taking care of patients, taking care of the community, but maybe not as much experience writing presentations or developing presentations, and you wanted to do this for a year or 3 to get started, you can actually get what some people call canned talks, so prepared presentations that you can utilize in your program. There is a fee for it, but depending on your situation, it may be well worth that fee. The other thing that you can do as you're thinking about setting up a curriculum for your programs is, do you want to go for a 12-month, an 18-month, or a 36-month plan? And when I think about that in my mind, I think about the drinking from a fire hose analogy of learning everything there is to learn in medicine or in residency training. There are so many topics. And everybody says, oh, I wish I'd known that earlier. You can't know everything earlier. It just takes time. That's the nature of the process, is you have to learn over time. As I think about trying to squeeze all the possible topics into a 3-year residency program, it can be a daunting task because there are so many various topics and you want to cover all of them. And I'll show you some math on how that looks in a moment. But there are some topics that are important enough that you want to cover them every year and make sure that you get both that initial education and then layer on for the people as they proceed in their training. We always keep in mind, it's like, gee, it seems like I just gave that talk. It's like, you did. You gave that talk last year, but now we've got new interns or the new second years, and we have folks that just graduated. So every year, it's all new all over again for somebody. So there are certain topics that are so important, you want to hit them every year. Then there are some topics that are extremely important, but in the prioritization, they may not be as important. So let's say there's a talk, it's important to know about adoption. What's the process of adoption? How does that affect families and how they grow their families? Very important topic, may not rise to the every year category. It might be the let's hit that once every 3 years. Or there might be other topics that you say, this is in between those two on the spectrum. Let's make sure that we do it every 18 months so that people are likely to get it twice. And we do know that sometimes residents might be on away rotations or might be tied up with clinical experiences and may not hit every didactic experience along the way. So that's why some of the repetition can be very important. So as you think about developing your own idealized curriculum and you start to do the math, a lot of programs will do a half day of didactic presentations. Wednesday or Thursday afternoons are common templates for that. And a lot of times they'll do 4 hours. Mike Tuggy, I think, actually likes 45 minutes instead of an hour. So you can slide in an extra topic there. Instead of 4, you could have 5. Some people only do 3 hours so that you can adjust. But if you have 50 weeks a year and 4 presentations, that's 200 each year, and that's a total of 600 over the course of 3 years. There are also other plans. Some people will do a daily noon didactic presentation, especially if your cohort, all of your residents are in one location and you can bring them together on a daily basis. It's a little bit harder to come together more frequently, but it's kind of nice to bring everybody in, feed them lunch. That can save time. So if they're working at the hospital and you've got a conference room at the hospital and the clinic is adjacent to the hospital, it's kind of nice. You can bring them in, save time. And when you feed people, you often increase your attendance because you're doing them a favor. They don't have to stop and spend the time to get their own meal together and then get on to their afternoon clinic. If people are more dispersed, then it becomes more of an advantage to get people together just for an afternoon or a morning and clump or cluster those presentations. There are other avenues for presentations also. If you find that you've got a ton of topics and you can't cover each one of those during your core didactic schedule, you can plan some of these in to be done during your inpatient experiences, for example. So keep in mind, it's like, okay, well, we're going to talk about hospital management of congestive heart failure, and we're going to do that while people are on their inpatient experience. Or we'll talk about fast ultrasounds so that people get that and might even be able to bring in an ultrasound and practice that. So we're going to have that both as a didactic and a hands-on opportunity as part of the inpatient experience, instead of doing that in a classroom situation. Or likewise, if you wanted to review physical exam skills, that would work out nicely for the inpatient service or management of inpatient pneumonia. You get the point in terms of those various topics that are really lend themselves to the inpatient area. For some people, they have clinic-based education. So in the clinic, they might get together, and prior to starting the clinic or at the end of the clinic, we'll go through a topic. And so you can build some of those topics focusing on outpatient medicine into your outpatient clinics, either in the before or after. And then, of course, on specific rotations, let's say somebody's rotating on pediatrics or internal medicine or surgery, then there may be core topics that are covered during those specific rotations that you don't need to worry about trying to build into your 3-year rotating curriculum if that's what you've chosen to do. So if you are looking at setting up a curriculum, it often helps to break it down into themes. It can be pretty intimidating to try and figure out, okay, how do we plug in all of these topics, and how do we sort them and organize them and put them into a thematic, makes sense type of presentation. So we'll just do a for example here in terms of family medicine curriculum. You probably have leaders in your programs that focus on inpatient. You have other people who focus on women's health, maternal child health is the abbreviation we use, or pediatrics, or you have a behavioral health expert, or somebody who does chronic care topics or wellness, and often somebody who does practice management. So you can designate point people to build out those aspects of the curriculum. You let them know, it's like, okay, you have this many hours or this many slots, and we want you to be responsible for these because that's your expertise. And that can help also with their development as a faculty and develop their national reputation as they learn more and more and focus more and more. They can teach not only in your programs, but then locally, regionally, nationally, as they build their expertise, their fluency, and their reputations. So when you're developing your didactic days, let's say you do Wednesday afternoons, University of New Mexico does Wednesday afternoon, you might consider that the first week, and this isn't necessarily how they do it, but for you, you might say, okay, for the first week, we're going to focus on outpatient care. And so we might have wellness or hypertension or immunizations or other things that we usually see in the outpatient curriculum, and make that the theme of the first Wednesday. The second Wednesday, if you've got somebody who is a hospitalist or does a lot of hospitalist medicine, you can have them in charge of the second week and cover your hospital topics. For the third week, you might want to focus on pediatrics and bring in all the pediatric topics and organize those themes together. Now, sometimes there's a fifth Wednesday. I believe that works out quarterly, that you'll have that extra Wednesday or Thursday in the month. And some people dedicate that to behavioral health or practice management if they're not devoting as many of those specific days to practice management or behavioral health. Or you may say, you know what, we really want to build out our behavioral health curriculum, and we're going to give them one of these weeks every month, and we're going to include substance use in addition to psychological care, and that way you can bring a lot of topics into that, especially if you've got somebody who's really strong in teaching for behavioral health. So those are some of the ways you can approach the curriculum. Some special aspects of building a curriculum are the first month when you get your interns, or if you're a 1+2 program, when you get your second years there, it might be not exactly the same, but we call it boot camp sometimes, or how to survive internship. And these are some of the topics that you want to repeat every year. Just like, okay, the nursing staff call you at 3 in the morning and your patient is having crushing substernal chest pain. Their admitting diagnosis was pneumonia. What do you want to do, doctor? So it's good to have that refresher every year, especially people who've just graduated from medical school, and say, okay, this is how you manage that phone call in terms of addressing their chest pain. Or you get the phone call, their potassium is 2.1. What do you do with electrolyte abnormalities? Their sodium is 116. The patient is seizing. What do you do with the patient who has these emergency things? They're hypotensive or hypoxic, or they have altered mental status. How do you approach that? Do you check their glucose, or their blood pressure, their medicines? And so those can be very helpful. And one of the things that you can do is your second and third year residents may be very well practiced already on these topics, and they actually probably field more questions from the nursing staff on these specific questions and topics than the faculty may have if the faculty haven't been doing a lot of hospitalist work. So you can have your second and third year residents actually teaching these presentations. So bring those local experts in, and you'll help to build those links between the interns and the second and third year residents. So that can be very helpful to do that. You don't always need all of those residents though. And so you might want to do some practice management topics for those. So you can actually break into smaller groups instead of having the whole group together. You can have people step out. It's like, okay, you know, Sam, you're doing chest pain. Jill, you're doing electrolytes. You know, Roger's doing hypotension. Susan's doing hypoxia. And they split off, teach those, but then come back to the upper level courses. So that way you actually preserve more educational slots for your upper year residents also. And the interns love learning from their senior residents, and that just generates the respect and value that your interns have for your upper level residents. So I think we covered this partially. We have at the University of New Mexico a residence as educators course. And so before you launch people out into teaching, you may want to also educate them on how to do some teaching. And we'll talk about how to put together presentations in just a few slides here. And it's also nice for them to know some of the precepting techniques that we do with our learners, so that our upper level residents can utilize those precepting techniques for the medical students that they're going to be supervising, as well as the interns that they're going to be supervising. So in terms of making your presentations as valuable as possible, of course, you all have your own opinions about what is going to be great content for the learners, and that's a wonderful place to start. The other thing you can do on top of that is you can do a needs assessment. So I find that medical students have different needs from interns, from third years, and from faculty. So there's a medical terminology presentation that I developed for practicing physicians, and there's one I give for the students. And I actually tried both of them out on the students, and the students didn't like the one for the practicing physicians. So I went back to the one that was geared, that I'd been using for students. So you'll find there's some variety. And I'll try to pull some opinions from people. So if I'm going to be presenting to the residents, I might say to one of the chief residents, what do you think would be really helpful in a congestive heart failure talk? What do you think would be really helpful in the hypertension management talk? So that I can hear from them how I should focus the presentation in terms of the content that they want. Because you want to be teaching to people where they're at. That will engage them more, that will help them more. One of the things that we know is we will likely in resident didactics have different levels of learners. So we'll have the whole spectrum across residents as well as faculty and students. And you can sometimes say, as a review, and then talk about some of the stuff that you would assume that they know as a baseline, but maybe they don't really know it as a baseline, and you can go ahead and present that information to get everybody on the same level playing field, and then move into more of the specifics. Sometimes you can engage one of the learners and actually have them, if they're confident, or a volunteer, have them give some of that baseline information, and then you can go ahead and move on from there. Some people will actually utilize a paper or electronic form that they can distribute to their learners with actual questions about what do you want to learn, what are some of the important aspects you want to take away, what formats do you like, or what formats would work well. So you can consider doing an actual formal needs assessment, or you can be a little bit less formal and just reach out to people. Literature review is always nice to do to back up what you're going to be talking about. Things change every year, so as you're doing last year's presentation, you can pull out last year's presentation and then do a quick literature search and see if anything's changed over the past year. Also, you want to think about what's the best way for them to learn. How do you like to engage your audience? And I'm going to hopefully engage you some more when we get to the question and answer portion later on in this presentation. But for this one, I am doing more of a distributing type of presentation to go through this. When you're doing your resident didactics, you might choose to do small groups. You might choose to do problem-based learning, where you have people do some research beforehand, do some pre-work, and have different people answer different questions. So it's like, okay, let's talk about heart failure again. It's like, so we want group A to check about the etiology. We want group B to learn about what's useful for physical examination. Group C, what's useful in history. And then group D, what's useful in treatment. Maybe if you've got 5 groups, what's useful in terms of labs and diagnostic imaging. And then you can bring those groups together and actually have them teach each other in that problem-based learning type of thing. I love to teach with clinical cases, especially with clinical images. You can use skin photographs, you can use physical findings, you can do EKGs, you can do chest x-rays. And so you can put up an image, of a chest x-ray of somebody who's got congestive heart failure and say, this is a 75-year-old woman who comes in with shortness of breath. Jane, can you tell us how you would read this x-ray and interpret this x-ray? And what do you think the ultimate diagnosis is? And that helps to engage people also. With that. I think I've covered everything on this slide here. Let's go ahead and open things up to questions and discussion. I see there's some information in the chat. I'm going to stop the screen share in just a moment. Time and your attention for today's presentation. My email is here for your reference if you'd like to reach out and contact me. So I'm going to stop the screen share if I can right here and check and see what we have in the chat, and then open it up to individuals. Great. So Esther checked out one of the resources, and the Primary Care Consortium has a subscription to the RCR, and we're saving questions to the end. Fantastic. Okay. Let's open up to questions. And we can head off on tangents and not just stay to this material if you have related questions also.
So I guess just like in terms of when we are creating and borrowing the curriculum as we're the new program starting up, one thing I would imagine would make kind of sense, tell me if you feel this is right, Dr. Stulberg, using, like, I remember the USMLE is broken up into different percentages, and like what's kind of the heaviest part. Maybe kind of mimicking that or mirroring that in terms of how we're breaking down all those presentations and the bread and butter. I feel like cardiology is always a big one.
That's a great suggestion. So definitely can you look at the USMLEs. There are also, I believe, in terms of the RRC recommendations, I think they have also lists of various topics. that you should be planning on covering for the residency education. And also as your residents go through their in-service examinations, the program directors and leadership will get to see how people are scoring on the various aspects on the in-service examinations. And you might find it's like, okay, everybody's doing great on women's health, but we're struggling on pediatrics. And so people aren't doing as well on those pediatrics questions. It's like, okay, well, let's go ahead and adjust our curriculum. Let's see what our deficits are, and let's go ahead and bring in some more presentations about pediatrics care so we can bring those scores up. What we're really trying to do is bring the education up, and the scores are just helping us to touch base on those areas where we need to make sure that the education is broad and also thorough and is sticking, because sometimes these things are tough and they need repetition in order to make them stick. So I love your idea of looking at the USMLE as a way of looking at some of the potential topics. Some people will actually use practice questions. So especially if you find that your team and your learners maybe aren't great test takers, sometimes they'll start the presentations with like a gathering activity. There's certain groups, they have gathering activities, knowing that some people will be a little slow logging on or may have, a little bit slow arriving. So you can do a gathering activity that's not mission critical to that topic. It's like, oh gosh, I missed the beginning of the diabetes talk and I'm totally lost. So instead, bring in some diabetes questions, some board type questions, and then you can go through those with the group and do a couple questions as a primer. Oh, you might be seeing this on your in-service examinations or your board examinations. Get people primed and thinking about that. And then, for the first 5 minutes or your discretion, 10 minutes if you want, and then dive into the core topic so that you don't miss that introduction to the core topic. Other people will do, in terms of gathering activity, be announcements. Some people will hold the announcements till later because the announcements are important. And then some people will just do some little catch up and socializing as a way of touching base with folks to see how they're doing while allowing people to gather and not having just open dead space there. Thank you, Tanya.
Dr. Stulberg, I have a question. My background is completely different than most of the folks here. I come from public education and taught for about 25 years. And one of my areas of interest was different learning styles. And I'm wondering, how is that incorporated into training residents, or is it?
So, great question. We do have people who have different education styles, different learning styles. One of the residents, could tell I was pondering. He came to family medicine residency after being a nurse practitioner, and his questions and his thought process was different than the average person who had just graduated medical school. And he says, "What are you thinking about?" I says, "I'm thinking how to best help you with your education." Because he was thinking practice management questions. He was thinking forward in terms of, okay, how do we apply this hypertension management information? And how do I figure out the various protocols and the various medications to use? So you are right. Different people have different needs. Some people are more auditory learners. Some people love to dive into either paper books or the electronic versions of books and do really well absorbing that information. Personally, I find it's a lot easier. I do better with auditory and visual than I do reading the textbook. Those just put me to sleep. Some people do a lot better with the case-based. So, and the medical literature shows that our usual just talk at people type of presentations, that at best they can retain 3 points. 3 educational points out of a 1-hour presentation. You'd think that they learned a lot more. Even the ones that are highly rated, it's like, oh, this was a great speaker. It's like, usually that means they were humorous or they were engaging, as opposed to I learned a lot from that. So one of the things that does make a good talk is good goals and objectives. At the end of this presentation, the learner will be able to diagnose congestive heart failure. Number two, be able to manage congestive heart failure. And so having those clear guidelines can be helpful. At the end, also a summary of what they've learned to solidify those points can be helpful. And if you're really good in terms of incorporating the didactics into your clinical practice or going back and forth, you can pull some of your clinical templates into your presentations or wrap up your clinical presentations with a template and say, okay, we've just done this presentation about well child visits. In the EHR, if you type in equals well child 4 months, it brings up the template. And so everything you've been talking about in terms of the presentation and the development and the immunizations will also be in a template so that they understand how you're flowing in terms of your clinical processes. So that'll help to engage people who like to apply things. And in terms of the case-based presentations with progressive disclosure types of questions, where you might just start off with just a one-line vignette about their symptoms, and then say what kind of diagnoses are you thinking about in terms of this patient with abdominal pain, and go ahead and open it up to the group, and then you say, and then you add some information in terms of imaging or a little bit more history. Let's say they just traveled from Guadalajara, and they have bloody diarrhea. Okay, now where are we going to be thinking, or where are we going to be going further with that? And then you might show an abdominal X-ray, and there might be free air. It's like, okay, now what do you see? Now what are we thinking about? It's like, okay, well, gee, they went to Guadalajara, but I wonder if they've got a perforated ulcer causing free air on their X-ray. Or you bring in some laboratory tests and let's ignore that X-ray. It's like they've got a lipase that's 3 times normal, or they have a CBC with a white count that's twice normal with a left shift. So you can do images and progressive disclosure and have people actually work out the information, or you can have them ask questions. They can ask the history questions, and then you can give them the information. And sometimes they ask questions that weren't really in the stuff you prepared, and as somebody with experience, you can flesh out the case a little bit more, because sometimes they ask wonderful questions that I didn't anticipate they were going to ask. And so then you can give history, or it's like, oh, I didn't ask that. Well, we'll have to ask the patient later. But you can play it that way. And those are some of the ways that you can have people engage. Mentioned about the problem-based learning, so having people do pre-work, so they do some of the information, or sometimes you'll have a senior resident be the one who presents the case. One of the things that I've found in terms of having people do pre-work, if you're able to build it into your culture and it works well and people have the time to do it, then that can be very successful. I have run into times where I've asked people to read a short article, what I thought was a short article, like a 2-pager, and be prepared to discuss it. And I find that 25% or less of the people have actually had the time to read it. And it's like in patient care, I don't really call it non-compliance. Like, I wish they had read it. And then I have to reflect, oh, well, we're on pandemic surge. Everybody's been working, 12 hours every day for the last 7 days. They really didn't have time to read that. So I've read it enough. And if they're able to participate in that discussion, that's great. But I can take over also and facilitate the discussion without them having read it. when I have to pivot like that? So that's an excellent question, Esther, and I've scattered a whole bunch of stuff. And so I want to reflect back to you two things. Did I answer your question? And then the second one is, do you have tools and tips and suggestions that you have found helpful?
Yes, you did answer my question. One thing that strikes me when I talk to other educators in other fields, aside from public education and the lower levels, is that they tend to limit the styles of learning to auditory, kinesthetic, visual, and those are the three major groups. But there actually are 7 or more types of learning, types of intelligences, which include music and nature, and it's pretty extensive. But the best resource I've found is Howard Gardner's Multiple Intelligences.
Mm.
And that's a really useful tool. If somebody's really stuck and you feel like they're not getting the material, there may be a totally different approach. And as crazy as it sounds, I've even used creating a rap to get something in somebody's head. Kinesthetic learning, making them walk while they're reviewing the material, whatever is helpful. I have a lot of information about that kind of thing that if anybody needs that resource, I'd be happy to help with that.
Those are fantastic tips and suggestions. I have seen some of the, in essence, the rap type of videos that make some of the learning a lot easier to retain. There's a cardiologist out there that goes through some actions in terms of heart rhythm abnormalities, and some of the residents have seen that and have enjoyed that, and so that can be very helpful. Thank you for sharing that. That's great to have those suggestions and your expertise.
Dr. Stulberg, I have a question. So just given that we've seen a lot of this movement towards, the virtual aspects, so doing didactics through Zoom, what are some suggestions that you might have for making those sessions effective, like highly effective compared to in-person sessions?
Great, thank you very much, Mario. So Zoom is wonderful and it's challenging. It opens up opportunities and some people hate it. So we have this whole dichotomy. I like to think about it in terms of its strengths. I mean, that's how we're able to get together, individuals from around the state of New Mexico to talk together and to be able to do this. So that's one of the strengths, is you can pull in learners from different geographical areas. And I think in the future, we'll probably be seeing more and more hybrid type of presentations. And the value that can bring is, if you have a resident who's on an away rotation or a clinic where it's hard geographically to get back, they can join in and pick up that material. It is also possible to record things. There's probably not as much uptake on some of the recordings as we would hope, but if we do catalog them, then some people can refer to those and utilize those for learning. Now let's talk about breakout rooms. Breakout rooms are interesting. They always take more time to set up and to distribute people into the breakout rooms than you would think. And so you actually lose time heading into breakouts, and you lose time having people return from the breakout meetings. And most of the time, once people get in there and they start the discussions, they find that they always want more time. So some people get really ambitious and they say, well, I'm going to have 3 different questions and we're going to do the breakouts, send people off to breakouts, discuss the question, come back as a group, we'll debrief, and then we're going to send you back out and do it again 3 times. That's too much. So try to limit the number of times you send people in and out of breakouts. Consider how you want to group people, and if you want to pre-group people in terms of their as a way to set people to go to the breakouts, or whether they can self-select on the breakouts. So you have the opportunity to cluster those, and whether you want to cluster them in terms of developmental groups, all the R1s together, all the R2s together, all the R3s, or you want a mix of R1s, 2s, and 3s together so that you get that mix of experiences. So the earlier ones learn from the more experienced ones, and give them a concrete assignment to work on with that. And keep in mind that maybe in the new updates of Zoom, but usually the chat doesn't carry over. So you might want to have sent out that information beforehand, or have some point people who have those questions to carry over, or just remind people, it's like, okay, get out your camera on your phone and snap a picture of these questions, because you're going to lose it in the chat. And I want you to take this information to the chat. Some people are doing, what's the name of the boards? I think it's through Google, where they have these electronic boards where you can put sticky notes on them. If your group has a lot of experience doing that and everybody's able to do that, that's great. But all it takes is for one person in that group to say, the link's not working for me, I don't know how to do this, and then you've lost 5 minutes of your didactic time. So keep things simple in terms of your breakouts into chat rooms and what you expect. And keep in mind that if you've got 3 questions, usually you'll only get through 1. Occasionally people will get through 2, but be very modest in terms of your expectations, in terms of what you can get out of the chat rooms. Although people do like to discuss things, and discussing things in small group is helpful, but try not to do too much back and forth would be one of my thoughts on that. Trying to think. Let me open it up to the group. What are other things, or what are things that other people have found that have made the Zooms either a great experience or not great experience?
A couple small things. One is starting on time, because if you start late, then people kind of don't show up until 8:05 or 12:10, and then it gets very frustrating for the people that are on time. So starting on time and ending on time and making it clear.
That's excellent. What else have folks found useful?
Oh, and having everybody muted when they log in. Sometimes I've been on large conferences where all 500 people have their mic on when they get on, and people have to, physically turn it off, and invariably somebody forgets and they go to check on something and their dog is just barking or something. So.
Thank you. That's an excellent suggestion. And it can be very helpful to have a moderator. So you have a second person who is present, and they don't have to focus so much on the content as your person leading the meeting from a content standpoint. And that moderator can be keeping tabs on what's coming through in the chat. Thank you. I'm looking at the chat. So somebody said Jamboards. That was the term that I was thinking of. Thank you so much, Nicole, for dropping that in the chat. So you can have somebody who's looking at the chat and bringing the questions in if the speaker is unable to do both of those, because when you're doing a PowerPoint, unless you've got multiple screens, it's really hard to see the chat come through. And also that person can mute people. So for the person who doesn't realize that they're not muted, you can just automatically mute them instead of saying Frank, because Frank's got their phone and they're walking and you hear every footstep crunch crunch. you can just mute Frank on something like that. There's also a feature in Zoom called the Spotlight. So a lot of depending on how your Zoom settings are, sometimes you've just got it in the checkerboard type of thing, but you may want to have a speaker spotlighted. So if you have more than 3 people on your Zoom, the host can spotlight as a number of people, and then they become big and they stay big. So if somebody asks a question, they don't end up popping up big on the screen. They stay small, but your speaker will stay big on the screen. So that's another thing that can be helpful in terms of utilizing some of the technology that we have with the Zoom. Great. Other tips that people have for effective, well, I'm going to throw, so while you're thinking about that, so other tips people have about effective Zoom meetings or other questions, and along those lines, our dermatology grand rounds, they periodically will do joint grand rounds with, I think it's Sao Paulo, Brazil. It's like, how cool is that? You know, to actually be able to do international grand rounds. And so, you know, on the screen, they've got, you know, a traditional lecture hall full of learners, and you can see through the remote feed, you can see their lecture hall of their people. And sometimes they're the ones presenting cases, and sometimes the folks from the University of New Mexico are presenting cases. So people have been pretty creative, and you can pull in some outside talent. Let's say there's a speaker from New York that you would like to present to your group. Instead of having to fly them out and put them up and take away from their busy schedule, where they say, I really can't devote 3 days to that. It's like, well, how about an hour? Can you give us an hour? And then you could link them in and have them present remotely. Other thoughts people want to share, other questions that people want to share. You've had wonderful questions and insights.
Dr. Stulberg, thank you so much for your time today.
You're so welcome, Esther. Appreciate your input and everybody, wonderful questions and joining us today.
Thank you, everyone. Thank you, Dr. Stulberg. If there are no more questions, we'll go ahead and wrap it up. Please feel free to contact me if you would like to reach out with any further topics. This presentation and the slides will be available on our website soon as we get those up. If you'd like to go check them out or have any questions and would like to refresh yourself. So round of applause and thank you all for such great conversation.